Hello, everyone. So in pelvic floor rehab session, what we are going to learn is more about the pelvic floor muscle. I request all of you to please keep muting yourself so we can have an undisturbed session. So I shared with you that we have to understand the pelvic floor, where this muscle is lying. So for that, we should know the bony landmarks. And these bone, we all are familiar with. This muscle is lying at the base of this pelvic bone. Yesterday, yes, I also showed you this kind of this muscle, this pelvic bone, the pelvic floor muscle, and they are forming a cavity, pelvic cavity, and in this cavity, a very good arrangement of all the organs. So if you just remove the organs, so you will find that in a female body, we have 3 openings into this muscle. So muscle is going to give openings to the canals. Canals are passing through the muscle. So the base, the floor is going, is having some doors, and through the doors, the canals are passing and they can perform their function. And doors will always do good functioning as per the requirement, closing and opening. So the pelvic floor muscles are 2 muscles. They are coming from one side, one muscle from right side, one muscle from left side, and they will merge into the center to form the strong base. And in that strong base, we have these pelvic organs resting. And this image is a very beautiful image in a cross section, how you can see the pubic symphysis. Behind that, we have a bladder. Behind, on the top of the bladder, we have uterus. Behind the bladder, we have vaginal canal. We have a rectum, and then anal canal. So there are important ligaments, external structure, which is very important to understand. If we are working with the female, very, very intimate area, private area, we should have all the detailed understanding about what is mons pubis, what is labia majora, what is labia minora, vestibule area, and different kinds of vestibular area. Please mute yourself. Please mute yourself. Make sure that you are not unmuting yourself, otherwise we will have wasting of time. Okay, so I also showed you yesterday that how there can be different vestibular area you can see in different female as per the aging. So, and as per this activities, whatever they are involved in. Okay, so this is the first part, very healthy structures you can see. In this, this is a clitoral hood, this is a labia minora, labia majora, urethral opening is not visible that much, and this whole smooth vestibule. So the vestibule should have this kind of soothing skin. And this is a vaginal opening, and vaginal opening with a hymen, and hymen is having a very small proliferation in the center. And now this female, this kind of structures can be present there, like, if the female is not sexually active, she is not inserting anything inside the vagina, or at a very early age. As per the aging, there can be effect, more proliferation into this area. The hymen can show more openings into the complete structure. So we discussed everything yesterday. Okay, there might be more bigger openings here. Okay, we call it as a more proliferations in hymen. And if there's no proliferation, complete blockage of the hymen, it means that is a congenital problem, imperforate hymen. In this case, if the female is starting the periods, she has to have some openings so the blood can leave the body. So she needs some surgical help. This is again the next kind of vestibular area. You can compare this structure with this. So in this, hymen is stretched out around the openings. So opening is quite big opening in this case. And this is again a picture where you can see the vaginal portion. So this is a not vaginal portion, sorry, vaginal rugae. So these kind of circular bumps, they are present inside the vagina. These bumps should not be present into the vestibule area. But after childbirth, once the baby comes through the vagina, so, and the 1, 2, 3 childbirth, females can have this kind of vestibule also. So there's possibility that you can see this kind of vestibule in a female, but that mostly 80-90% you will see after childbirth, vaginal birth. Okay, the presence of the rugae in the vestibular area. So the area will not be the Sudan area, Sudan vestibule. And in this, you can also see on the top, this one is a urethral opening. This one is a urethral opening over here. Okay. So more protruded urethral opening. Urethral opening should not be that much visible. In this case, you can't see urethral opening. Even here also, it is very hard to see urethral opening. But in this, it is visible. So we call it as a urethral prolapse. Sometimes urethral canal can start coming out, like protruded outside. So that can also, you can see. And we also discussed that in this vestibular area, we have these two openings for urethral and the vaginal, as well as we have some openings of the glands. And the glands are present 4 and 8 o'clock and of both the structures around the urethra also and around the vagina also. So whenever we need opening and closing around this, so we are going for urination. So during urination, the urethra will expand. Once it will expand, it will put a pressure over the glands and the glands will keep secreting some kind of lubrication outside. So the female will not, and urine is acidic in nature. So that can create a kind of dryness around this area. So we don't want dryness. So that's why the skin's gland will keep secreting lubrication and female will have a healthy flora. Same way, whenever we are inserting something inside the vagina or any activities, so when expansion is going on, stretching of the vagina, that is going to lead the pressure over the Bartholin glands, and Bartholin glands will secrete some kind of lubrication to keep moisturing. So this stretching will not give unnecessary dryness to the female. So yes, we discussed that yesterday. I also told you about very important organ of our body, that is clitoris as a female. And clitoris, the glands of the clitoris, which most of us, we are familiar with this much of the part. And many females and even most of the people in the world, they think that female is having only this much of the clitoris. And we name it as a P-shaped clitoris. So, but this is the one part of the clitoris. Clitoris is our main sexual organ, which is hidden inside, beneath this vulva, whole vulva. It can, the vestibule, behind the vestibule, we have a vestibular bulb. Behind the labia majora and minora, we have this more bigger surface, the bigger organ lying there. And this is our primary sexual organ. So whenever female is excited, this is going to show erection is going to happen into this. Like males, they are having erected penis. We are having an erected clitoris. So clitoris is homologous structure to the penis. And we have the same structure. There are 4 parts of this. We have, you can see the legs are there. We have the shaft, or we also have a shaft or body. We can also see that. And we have a glans. So this is the structure, and this is the root of the clitoris, and from the root we have this bulb of vestibule is also coming outside. So this is very, very sensitive to touch, this whole structure, complete structure. And the entire length, this is not only P-shape, it is quite big organ, and it can be like this can be the size 3.5 to 4.5 inches normally. And once the female is erected, so this is like 4 parts. Clitoral hood is the part which is covering the glands, then glands of the clitoris, body of clitoris, crura of clitoris. We explained that yesterday. So once we are not excited, we have a flaccid clitoris, like male are having flaccid penis. So in this case, our clitoris whole structure as well as the bulb of vestibule will be flaccid. And as we are aroused, we are ready for sexual activity, the body is sending blood supply towards that area. The sex hormones are secreted by the brain. So that is going to give, they are going to go towards this particular area and they will activate the area. And the feeling will come into picture. And all the cavernosas into this, the empty spaces, as this is the erectile tissue, it has a cavernosa, so they will start filling with a lot of blood and they can get erected. So this is the differentiation. You can see flaccid penis or erected penis. So whole structure is going to go for lengthening. And in this time, you can also understand the legs will be more erected. So erections happens into the legs and the vestibular part. Erection don't happen into the body and these glands, because body is fixed with the pubic bone. So we don't have any that much erectile tissue into this particular body. We have erectile tissue into the legs. I also tried to give you understanding yesterday that how this clitoris is present there in correlation with other organs. So this is a very beautiful picture which can tell you. So this is the clitoris with glands, vestibular glands. And now this is the bladder. So we have a pubic bone here. Okay. We have this all pubic, like mons pubis here. So this is something, the clitoral glands of the clitoris. And now you can compare behind the pubic symphysis, we have bladder lying. And this bladder has a urethra. So this urethra is going to pass through this. And we saw a video also. I shared with you the video. So how it is just passing it. So very near. Same way, vagina is also passing. So it is encircling both the vagina as well as the urethra. And the part which you can feel that, sometimes always, whenever we have intercourse inside the vagina, so the penis or any sexual object, it will touch the anterior wall of the vagina. Vagina has 4 walls. One wall anterior towards the pubic symphysis, one wall posterior towards the rectum, and 2 lateral wall. So once the penis will go inside, or even the finger, if you stimulate with your finger, and you will follow the anterior wall of your vagina, and you will do some stimulation on that area, you will touch that area. So just on the 12 o'clock position towards the pubic symphysis, 12 o'clock position inside the vagina, you will feel urethra. And if you will move your finger, not 12, you will move your finger on the sides. So it will be 1 o'clock. It can be 1 o'clock or 2 o'clock. So that is a position where we can touch the bulb of vestibule, this clitoral structure. Vagina is like a condom. It's like a collapsed structure. It can get or kind of too much of stretching. So once you will touch from that area and you will do a stimulation, so 1 or 2 o'clock, and the other side, right hand side, it will be 10 and 11 o'clock. So 10, 11 on left, 1 and 2 on right. If you'll do a very smooth, very mild stimulation, and if you'll give yourself, if you are sexually, if you'll just think about sex, so you'll get this very good sensation. So these are the part, we called it as a G-spot. So more sensual part inside the body. Same way, we have another, so this was the clitoris we understood yesterday, and we have a urethra. Bladder is an organ which will keep filling the blood, this urine, and after the filling, it will keep expanding also till the time it can expand, it will keep stretching, but there will be one time will come that we have to void. So once the urine has to come out from the body, so we have this urethra for that. And female urethral length is very small. It's around 3 to 4 centimeter long only, and 5 to 6 mm the width is that. And it has two doors. One is towards the urethra, towards the bladder, and one is into the vestibular opening. So we can see sometimes that particular urethral opening into the vestibule. So there are two, it opens into the vestibule. Same way, we have another organ inside, that is a uterus, and uterus has a canal, vaginal canal, and the vaginal canal is having this kind of whole mucus layer, and the mucus layer is having the round circular lumps, ring-like structure. And we call this as a ruggy, this particular mucosal layer of vagina. And vagina is very, very, it is a part, like, yeah, it is a part of sexual as well as reproductive system. But if it is mainly the responsibility of the vagina is collecting the sperm. So it is not providing a sexual sensation. It is not that much sensitive because our sexual organ is lying outside, that's the clitoris, but still it can give us a sexual sensation. Yes, the main responsibility of vagina, that it is a part of reproductive system. Penis will come here, ejaculation will happen, sperm will be collected by the vagina and then transferred towards the cervix. This is the first responsibility of this. And I also told you that if you just assume that the whole length of the vaginal canal, so and then divide this length into two halves. So upper half has too much of blood supply, and because of too much of vascularity and blood supply, this part is responsible for lubrication. So there is too much of this mucus layer is very lubricated. It will keep secreting the lubrications, and our healthy bacteria, the lactobacilli, is also present into this particular part. So to make our internal organ safe, so nothing bad bacteria or should go and towards the cervix and can start, in fact, giving this infection to the uterus, because uterus is having also this kind of canals, and these canals are open canals into the abdomen. If any infection will go, it will do infection. It can infect the cervix, it can infect the uterus, or it can infect the fallopian tubes, and it can spread this infection into the abdominal cavity. So we don't want that. That's why our vagina is having a very healthy structure, and even our cervix is more healthier than that. It has a different pH level, which is very acidic. 2 to 3 is the pH level of cervix. So in that environment, no bacteria can survive. And vagina also is having the pH level around this upper part, especially. It has the pH level around 3.5 to 4.5, which is somewhere acidic. So in that acidic environment, alkaline or those bacteria which, like, they cannot survive into this. So only healthy bacteria, lactobacilli, can survive, and the lactobacilli will keep making our ecosystem more healthy. So this is the part of our upper 1/3. Okay, and this, whenever we are talking about the lubrication issues, or we are having dryness, so that part is somewhere affected. So this estrogen hormone receptor is going to create, this kind of effect. So whenever some kind of chemotherapies are going on, cancer happens, cervical cancer, if some treatment is going on around the cervical area, they can create a dryness, they can damage this area. And because of the damage of this area, female can have this issue of dryness. So this is because of that upper part of the vagina is somewhere altered. Okay, so this is more responsible for lubrication. The female who are suffering from there's no cervical cancer and things are going on, but still she's feeling during menopausal time period, during lactation, whenever estrogen hormone is down in her life, so she might feel that there's a dryness issues, lubrication issues. In that case, we are advising our female to bring her finger more deeper inside the vaginal upper part of the vagina and try to stimulate this area. So once she will stimulate this area with touch, so there might be activation of the blood or this capillaries. So that this area is always having some kind of lubrication. So this female can drag the lubrication outside by moving the finger, by using the finger. They can drag the lubrication outside and start lubricating the outside area by draining this fluid from more inner part. And this part will also have a liquid and the secretions not only from the vaginal mucosa, but this is also going to have a secretion from the cervix. Cervix also has a mucus. Many glands are present inside the cervix, which will keep secreting some kind of liquid. So this area is mostly wet, more inner area. The dryness will be always into the outer, it can be over the outer side. Now, the lower 1/3, so that was the upper part of the vagina, that was that specialty. If we talk about the lower part, so we understood that lower part, the first thing which, now again, you can divide the lower part into two halves. So I'm just erasing the upper part, so not any clarity. So now let's divide the lower part into, again, two halves. So you can see the lower half, vestibular area, like here. So here there might be the presence of hymen tissue, that tissue present here mostly. And then very soon, this is a part where our pelvic floor muscles are lying. These are the pelvic floor muscle. Okay, they lies at the bottom of the door of this canal. So very bottom. So again, we can see that this outer part here around the orifice, we have a muscle, superficial layer of pelvic floor, and deeper we have a deep layer of pelvic floor. So these two muscles will try to form a kind of tunnel inside. Okay, so once you are going, once you will go inside the vagina, you have to open two doors. One door is the door from the bulbocavernosus muscle, superficial muscle. That muscle should be relaxed and open, and there should not be any spasm into that muscle, and the relaxed pelvic floor, so you can touch the orifice. So now this is the one part outside, this part. So we have a one muscle here, superficial muscle, bulbocavernosus. So this is the outer part, outer door of the tunnel. So this is one outer door, okay? And this is the inner door of the tunnel. So assume it is a tunnel, you are going into the tunnel. And after that, we have all these stretch, mucosal, smooth muscle layer. So this whole vagina is made up with smooth muscle. But the entry, around the entry, we have skeletal muscles. Smooth muscles we cannot train. But the entry, if that entry, the muscles are like, if for example, vagina is very lax vagina, not feeling any sensation. But if you strengthen the gate, the door, so yeah, grasping power, sensation, grasping power, proprioception, tactile stimulation, we all can increase that. And holding capacity, you can close the door. So these doors, and if the doors are very tight, we can relax the door. So we have these two areas of the vagina where we have a deeper pelvic floor muscles and the outer pelvic floor muscles. So these pelvic floor muscles are making this vaginal door close and open, opening and closing. And the second is, not only the pelvic floor, this lower part is also having estrogen and testosterone receptors present here into this lower part, okay? Now over here, as per the presence of the receptors, whenever female will have this secretion of the testosterone and estrogen level in her body, so this area, this mucosal cells has a special skin. This particular part has a special skin. They are going to give her a sensation. So she will be, if you touch this area, once estrogen, testosterone is there, like during the ovulation time period, this is our main time. So when you are this fertility window, 2 to 3 days before that, ovulation and that day of ovulation. So this is a particular time when we have a high level of sex hormones running, secreted by the brain. So that sex hormones are making these areas more sensible to touch. Sensations will be very high around this. And now this is this was the second, first is the pelvic floor, second is this estrogen receptors, and the third is, this is the same area where you can feel that clitoral and this encircling. So this is also at the downward part. It is not into the deeper part. Okay. So it is just around the very, as soon as you will enter your finger, if it's 1.5 knuckle, left and right, you can touch this clitoral network, posterior part of this clitoris network from the vagina. So these three things are making our vagina very, very sensitive. That's why we can feel sex. We can feel, we can even hit orgasm inside the vagina. Okay, we can feel maximum sexual sensation. These important qualities are making vagina sensitive, and female can have, she can enjoy the sex through the intercourse. This is again, we try to understand that how our organs are placed there. So it is, now this is a pubic symphysis anteriorly, then bladder, urethra. This is our uterus with vaginal canal, long vaginal canal. I also told you yesterday, as well as you will insert your finger. This is the pelvic floor muscle. So once you will insert your finger inside the vagina, just up to 1.5 knuckle, you are going to at around anterior wall. If you just keep touching the anterior wall up to 1.5 knuckle, you will keep palpating the urethra, okay, urethral canal. And once you will be more deeper into the vagina, then you are going to touch the posterior part of the bladder, like you are following the anterior wall. So this is how we can insert our finger anteriorly. So whenever, as a physical therapist or as a pelvic rehab therapist, we are doing assessment, our finger is always towards the pubic symphysis, following the entry towards the anterior wall. So we can feel the structures. And at the posterior wall, if you are feeling, if you are moving your finger posteriorly and then you are going, so you will feel the rectum around there. Okay. And this uterus is lying there in anteverted and anteflexion positions. And sometimes these angles are very important. This uterus is there with the help of many ligaments and supportive structures. The first supportive structure is this bladder. Second supportive structure will be the rectum and the ligaments, which is like or holding the uterus. There is a broad ligament on the sides, anteriorly round ligament, posteriorly uterosacral ligament, the pubo-cervical ligament. Many ligaments are present here. Small, many structures which is supporting it. And the pelvic floor is also there, which is maintaining the posture. So the organs will not falling down. So pelvic floor will be also there. And we have a rectum wall. We have a rectum, and this is a rectum, and rectum is again 3 walls are present: peritoneal cavity, mucus. This is smooth muscle. Middle muscle is a smooth muscle, and more inner muscle is a mucosal layer. So this is all mucosal skin is present. The sheath is present over here, which is very shiny skin. So these are 3 layers, and the whole this part rectum is the same kind of, so this is a smooth muscle, same kind of smooth muscle will form the anal canal. And so this is a smooth muscle, we call it as the anal canal, we call it as the internal sphincters of anus. So this internal sphincter is not under our control because they are made up with the smooth muscles. Okay, that kind of arrangements are there. And these smooth muscles are starting from the in to out, all the passage, the smooth muscles will be lying. And on the out of it, now in this one, if you'll see, this is a skeletal muscle. We call it as a external sphincter. Okay. And in this, so this is one muscle, this is the second muscle, and this is the third muscle. Okay. So 3 muscles are present, which is forming the external sphincters around the not external, which is somewhere outer layer, the skeletal muscle layer, which is present there around the anal canal. So we'll understand that now in our upcoming slide. So now let's try to understand the pelvic floor. We have some ideas about the organs, but still we have to understand how the uterus functions, how the bladder functions, and how the rectum functions, because their functioning can always affect the pelvic floor, and pelvic floor can always affect them. So they are correlated. Okay, so we will try to understand the pelvic floor. So let's start with the pelvic floor. Now, this is, I told you yesterday that if the pelvic cavity, this is a pelvic bone, the pelvic bone really needs some kind of base of support down there, so it can hold the pelvic organs. So that's why we have the big, very, very important muscle, big muscle, and that is the pelvic floor. If I'll ask you how many pelvic floor muscles we are having in our body, please write down in the chat box. How many pelvic floor muscles are there? Gomati? Okay, everyone keep writing, keep writing. If our complete pelvic area is behaving as a wall and home where our pelvic organs are lying, so it means our pelvic floor muscle is the base, floor, or foundation of that home. So this is the pelvic organs, this is the base of this. This image is very important image where you can see that how many structures are present from front to back. So pubic symphysis we can palpate. You can palpate now over here. We have a clitoris, which is going on the side. And then we have a urethral opening in the vestibular area. We have vaginal opening. Now, this is a very important hard tissue that is a perineal body, which is present there. And same way, we have anococcygeal body is also present there. Okay, and then we have this tailbone, coccyx is present. So pubic symphysis, and then perineal body, and then anococcygeal body, and then tailbone. So it is very important that we should have this understanding that these are the parts which is going to provide stability. They will be the center for the stability of which we really requires high level of the stability into this area. Okay, so these parts are providing the stability. So I got my answers. Let me check. There are 15 plus 2, Kajal, 15, 15, 15. Yes, yes, yes. Okay, Jensen, Kajal. 3 accessory muscles. Go. Okay. Got it. Got your answer. Thank you. Thank you, everyone. Yes, you guys are right. Actually, we have altogether 15 pelvic floor. Like pelvic floor is not one muscle. It is a network of muscle. And in this network, these muscles are lying in different layers. So we have 3 layers: superficial, middle, and the deeper layer. And in this layer, altogether, if we count the muscles, so they are 15 main pelvic floor main parts of the pelvic floor. 15 muscles are there. And yes, we have 2 accessory muscles: obturator internus anteriorly and piriformis posteriorly, which is helping us to form the walls of the pelvis. So if this is a pelvis, this is a pelvis. So these are the pelvic floor, but this is the area where we have a piriformis. So the piriformis is forming the wall, and anteriorly we have this one, obturator internus. So these 2 muscles are the accessory muscles. They are not directly related to the pelvic floor, but they are supportive. They are closing the walls. And even the obturator internus, it has a fascia, and from the internal obturator fascia are levator ani muscle. That origin of the levator ani is from the fascia of this obturator internus. So we will understand all this in upcoming slide. So this is where we stopped yesterday, isn't it, everyone? Did we discuss this slide?
No, Dr. Sunita, we ended up till clitoris and the anatomy of the reproductive system.
Yes. So now we are going to start the day pelvic floor. So pelvic floor muscles are a group of muscles which are working together to perform its function more efficiently. They are a group of muscles. Now, if I tell you, do Kegel, okay, do pelvic floor's contraction. So in your brain, the whole muscle will come and you will try to contract the complete muscle. So these muscles can work in a team, as a team, to create a very good, strong contractions, upward contractions. And if I tell you that, okay, do relaxation, we don't have to contract. So just relax your pelvic floor. So then a downward movement will happen. So this is a reverse Kegel we need in case of hypertonus cases. So now the muscles can contract like other muscles, and it can relax, and it can also work in a coordination. Like, what is my need? My need is urination. So once I want to urinate, at that time, I don't want to defecate. So only that muscle which is around the urethra, they will open, and the muscles which are around the rectum, they will not open. So muscles can also work isolately. Like, they don't need that work only. Always they are not working as a team. So whenever the need of, if you are defecating, that muscles of the posterior part will open, and you are not urinating at that time. So we have 3 canals in a female body. Out of these 3 canals, 1 canal is working at one time, 2 other canals will not work. So one will be opening, the one will open, the one will relax, other 2 will contract. So depending upon what we need, as per this, in a coordination, our pelvic floor muscles are working. And you never defecate and urinate on the same time. And if our patient is doing that, urination and defecation is going on into the same time, it means the pelvic floor dysfunction is there. So that should not happen. So let's understand the more efficiently, effectively work of the pelvic floor by understanding the pelvic floor muscles individually. To understand that, now I want all of you to palpate your pubic symphysis anteriorly. I want you to palpate your tailbone posteriorly. And I want you to palpate your ischial tuberosity. So these are 4 points, and you do marking of these 4 points. You can take a paper, sit down on a paper, and try to mark your 4 bony landmarks on the paper. Okay, so you can mark it. This is what we are doing for our patient, and I'm going to teach you into the workshops. And now join all these marks together. Once you will join them together, all these surfaces, you will find a very beautiful diamond shape. So this is what giving this terminology to our pelvic floor, that our pelvic floor is a diamond shaped muscle. So the corner of the diamond is attached anteriorly with the pubic symphysis, posteriorly with the coccyx, and on the sides with the ischial tuberosities. The diamond, this diamond can further, it has to divide into two parts. So it is further divided into two parts. One is upper part. So now take your ischial tuberosity. So we have in the center here, perineal body. Okay. So now from ischial tuberosity, draw a straight line towards the perineal body, and another ischial tuberosity come towards the perineal body. And once you are joining them together, you will find two triangles. One is the upper triangle and one is the lower triangle. The upper triangle, which we found, this one, this triangle, we are having our vulva. So we have our mons pubis, we have our clitoris, we have our urethra, we have our vagina, we have all the glands. So we call this area as a uro, because urinary system is present there. Uro and genital system is also present there. So UGT, so urogenital triangle. And the downward part beneath this, we have a anal canal or external sphincters. So anal canal is present at the posterior part. So we call this area where the anal canal is present anal and rectum. So anorectal triangle. So why it is important? It is important for our documentation as a physical therapist. So if your patient is coming and he has a problem or she has a problem of constipation. So constipation is area which lies into the anorectal area, anorectal triangle. So our documentation will always start with this anorectal triangle. So problem is there in an anorectal triangle. So we will focus into this area. So if this is written, if I'll send my patient to you and if this is written into the file, your focus, you will get to know that, oh, okay, something happened around the anal area. Same way, if my patient is suffering from sexual problem, so sexual problem is not around anorectal area, it is around this, in case of females we are talking about. So that is around the vagina. So that is the case of urogenital triangle. So if there's a urine incontinence, so that is a case of urogenital triangle. Okay, so this how we divide this diamond into two triangles, upper urogenital and lower the anorectal. Now this pelvic floor has 3 layers, as I told you. So in this, the first important thing is that you palpate your pubic symphysis, okay, over here. And the second, as I told you, ischial tuberosity. We have to palpate the ischial tuberosity. So palpate ischial tuberosity and draw a straight line towards the perineal body into the center. So this particular part, the space between perineal body and ischial tuberosity. So now we have very important muscle lying there. That is a muscle of superficial layer. Okay. Yeah, after superficial, we have a middle. After middle, we have a deep. Deep layer, we call it as a levator ani muscle. Okay, that is also levator ani muscle, endopelvic fascia. This is all the names of the deep layer. So let's understand the superficial layer first. The first layer. So to see the first layer, you have to remove the skin. So the skin, which is all present on the top. So this is what we are talking about. We want to understand this particular structure. So if you want to see this structure, these are the muscles. If you want to see this structure, you have to remove the skin. So we know that we have to give this understanding to our patient, the patient education, the patient counseling, consent taking, many things are there. We will discuss about this in workshops. But yes, in this one, if you want to see this area, if you want to see these muscles, so the skin layer is there. So you will remove the skin. But in this picture, you can see this is the labia minora. Okay, so the skin is present. Labia minora, and now downwards here is this is the labia minora, urogenital part. This vestibular part. This is on the top, clitoris, glands of the clitoris. This is the second one is the urethral opening. The third one is a vaginal opening. Okay, this is what you can see. And you will go more down. This is vaginal foreshape, lower part of this clitoris, minora. You will go down. You will go down, and you will find this is the anal canal. Or more back, you will go posteriorly. This is the tailbone. Okay, this is the anococcygeal body. and this is the tailbone. So these all structures are present. Now, middle part here, the space between the vagina and the this anal canal. So this particular part, and then palpate your ischial tuberosities. Ischial tuberosity. So from ischial tuberosity, we have to travel. Okay, let me come like this. So from ischial tuberosity, we have to travel all the way towards the perineal body, down part of the space between these two. So from this to here, one muscle is lying, okay, beneath the skin. So we have a skin. Beneath the skin, we have the muscle line. So if you touch the skin and you'll ask a female to contract, you will feel the contraction over here. So this is a pelvic floor muscle, superficial layer of pelvic floor muscle. So in superficially, from ischial tuberosity towards the perineal body. So origin is from ischial tuberosity and insertion is into the perineal body. So the name of this muscle is superficial, and can you see the fibers are transverse? Okay, so superficial, transverse, and the fibers are going towards the perineal body. So superficial transverse perineal. This is the name of this muscle. Superficial transverse perineal, STP. And same way, you can go again towards the pubic symphysis and then palpate, follow all these pubic rami and try to go towards the clitoris. So we have a clitoris here. So once you will move your finger from by following this ischium all the way upwards like this, and this is an area where we have another muscle. There was a transverse fiber. These are the longitudinal fibers. It is important to understand the can you also demonstrate how a retrograde muscles looks like and what affects symptoms? Yes, we will discuss that in upcoming sessions. Don't worry. And so this is a longitudinal fibers, and in this is one muscle where you can see this muscle is coming. Okay, and beneath this muscle we have our legs of clitoris. Can you see? This is the legs of clitoris. So this muscle is on the top. It is overlapping the legs. So legs are behind and muscle is on top of it. So this name of this muscle is ischio, because it's coming from the ischium, following the ischium, ischio, and going towards the cavernosas. So Ischiocavernosus muscle. This is the second muscle. Ischiocavernosus. Okay, superficial transverse perineal, superficial transverse fiber towards the perineum. Superficial transverse perineal, first muscle. Second, from this upward ischium, ischiocavernosus muscle, IC. STP, IC is the small name. And then you can also see like they are right and left, two muscles. So right and left. From the perineal body itself, if you keep moving towards the up by following this labia majora. Okay, so this is the labia majora part here. So you keep touching the labia majora and keep going upward. So this, but beneath the labia majora, we have another muscle lying here, and this muscle is over the bulb of vestibule. So in this image, you can see the bulb of vestibule, the bulb which is attached with the clitoris, the bigger kind of structure. So this bulb, this muscle is over the bulb. So we call the name of this, and this is going all the way from the center, perineal body, origin is from the perineal body, and insertion by going upward, upward, insertion is around the clitoris. It is inserting into the clitoris, base of the clitoris, sorry, body of the clitoris. Okay, so it means the name of this muscle is Bulbospongiosus. We called it these openings as a cave. They are like caves. Okay, so we call it as a Bulbospongiosus muscle. So these Bulbospongiosus are the gate, the doors of where you have a structures, urethral opening and the vaginal opening. And beneath this, the bulb is present. It is overlapping the bulb. So just try to understand if the muscle will contract, if this specifically muscle will contract. So what will happen? There will be pressure over the bulb. And female will have it can increase lubrication. Okay, so contraction of this muscle can activate the bulb, And bulb is highly sensitive also. And this muscle is going to even or insert into the clitoris. So contraction of this muscle is going to give you some kind of clitoral action also. And this muscle contraction we are talking about, okay, the contraction will compress this, and contraction will have an action of the clitoris also. Now, bulb, it is around the openings. So if something is present around the opening, so means I want to urinate. So during urination, some relaxation will happen. So mild opening will happen. Again, I want to hold. So closing action will happen. So this muscle, if you want to insert something inside the vagina, so you will close and open vagina. You want to insert something, or you want to hold the vagina. You want to hold something inside. Like, for example, you have to hold the tampon into the vaginal orifice, so you will be able to hold. So this muscle is going to create contraction and relaxation. So opening and closing effect is there of this muscle. It is not a main muscle of sphincter. Sphincter means complete closing, compression. It is not very like muscle which is performing the sphincter, but yes, it has an opening, closing, opening, closing. That role is present of this muscle, Bulbocavernosus. Once we talk about the Ischiocavernosus, this one, so you can understand if this muscle will contract. So contraction of this muscle is going to put a contraction over the legs. So this is the main muscle of our body, which has a sexual role. So if I'll ask you which muscle is giving us the sexual functioning, help in sexual functioning. So that is the Ischiocavernosus muscle. And this muscle will keep once the female is aroused, she want to have sex. So at that time, blood is very fast, blood supply is very fast around this area. So at this time, this Ischiocavernosus will start compressing, and this is a fast twitch muscle fibers. The superficial layer is a fast twitch muscle layer. They are going to create a compressions and pumping action, and because of the pumping action, the blood will move more towards by crossing the legs and towards the whole glands. They will create a filling of all these cavernosas, which is present in the body as well as the complete legs. So this muscle is going to help into the filling of this blood, erection. So these muscles are going to give us erectile effect during the sexual activities. And the same muscles are going to help us during the orgasm as well, when we are going to hit the orgasm. So this reflexes, Bulbocavernosus muscle, it will reflex, fast twitch action. So this is going to help us into orgasm. And same muscle, Bulbocavernosus, so these two muscles, sexual, this is also a sexual role. Okay, the Bulbocavernosus also has a sexual role because this is a sexually sensitive bulb. So these two are the sexual muscle, and out of these two, this is the primary sexual muscle, which can help into erection. And if we are saying that which muscle can help in like sometimes vaginismus is a case, like no penetration, painful penetration, something is hitting you, muscles are very tight, so you cannot go inside. So in this case, this muscle is tight, Bulbocavernosus muscle. This muscle is spasmodic, and because of the spasm, it is not going to relax. It will not relax. So opening will not happen, door will not open because of the tension, because of the spasm into this muscle. There can be many trigger points around the whole fibers. So trigger points, bands, like you can feel bands anywhere else in your body. Same bands and trigger points you can see, you will observe with your fingers, palpation around the Bulbocavernosus. So they are the muscles which get tense. If the muscle will get tense, depending upon from here, but trigger points are here, this part, this side, or they are upside over here. So where the trigger points are, if they are here, so opening of the vagina will be problem. If they are here around the urethra, so yeah, painful urination can be also there. Okay, so this muscle is the opening and closing effect is going, and this muscle is again a muscle of the sexual. Now, what is the role of this muscle then, which is going from the ischial tuberosity towards the center? Now, Bulbocavernosus this muscle originated from the perineum, and insertion is inside the clitoris. This muscle, Ischiocavernosus, originating from the ischium, and insertion is into the clitoris. So clitoris is this particular part is the one part where two muscles are merging with each other. These two. bulbo as well as ischio. They will be somewhere attached with each other. The circles will merge, the fibers will merge with each other. And this is a very main site in females who are vaginismus. So they are suffering from sexual pain, vaginismus, pelvic floor muscle spasm. This area will be more tense, more trigger points will be there around 1 o'clock. You can see around 1 o'clock, 11 o'clock. So these will be more like, specific area where they will be 90%, 100%, they will be trigger points, more spasm. Okay. So now what is the role of this muscle? From coming from here, the origin is from and insertion is into the perineal body. So what is the role of this muscle? What can be the role? Stabilizer? Yes. This is a stabilizer. Okay, because we need stability, the center. So from the ischial tuberosity towards the center, this one muscle, other muscle, and they will merge into the center. So this is a stabilizer. It provides the stability. Okay, like this. Now, once we are talking about pregnancy, relaxing hormone is there, relaxing hormone, because we need more bigger surface, baby has to come down into the pelvic cavity. We need to provide the surface to the uterus. Uterus is growing, baby is growing. So at that time, relaxing is going to create all the stretching in all these muscles. They will be, expanded. So this is right now, if my pelvic, my ischial tuberosity are like this. During the pregnancy, they will be more widening of the hip is going on. So widening means these two bones are going away from each other. Okay, widening is going on. And that is going to create a laxity into these muscle fibers. Okay, superficial transverse. So that's why stability is an issue in a female after even postnatal. If during childbirth, if there's a midline episiotomy, there's a cut into this muscle, okay, up to half. So what will happen? Cut is going to separate these two muscles from each other. So separation. So that's why many females after postnatal, after childbirth, they have a stability issues around this area. And once they will be cut, and after the cut, there will be, now the healing will happen, scarring will happen. Scarring can do, again, the fibers will come closer, they will stitch the fibers, but that might lead adhesion or some kind of tightness and restrictions. So this female can again feel some kind of pain and tightness into this area. If she will develop the pain and tightness here, that can happen in episiotomy, midline episiotomy, that can happen in perineal tear, because the stitches will create a adhesion and scarring. So this muscle action will not be that smooth. So this, whenever female will go for sexual activity, we need opening. And for this opening, now already there is a scarring over there, restriction. So this can give pain to the female later on after childbirth. This is what we are calling it as a secondary vaginismus or secondary dyspareunia. So sometimes these muscles are tight, there is stitches into this muscle. For example, so the cut is there into the bulbocavernosus also, because there's the central muscle and the downward also. So that cut can give them pain. Or if there's a mediolateral episiotomy from one to other side, so you can see it can cut on the one side. It can also provide the stability. So this female will have a tight one side of superficial transverse perineum is tight as compared to other side, because nothing happened to other side. There was a relaxation during the pregnancy. That is a relaxed muscle, but not torn muscle, not damaged muscle. But this one is a damaged muscle. So this side can create a adhesion, scarring, shortening of this side. Stability, instability can happen in a patient. Okay, and if this will be tight, so you can understand that what will happen with the whole, how it is going to change the biomechanism. So these are very important 3 muscles in a female body which is present into the urogenital triangle. So mainly 2 muscles, bulbocavernosus, this one, and ischiocavernosus is the muscle of urogenital triangle. This superficial transverse perineal, these muscles are, it is like a controversial muscle. Some books will tell you that this is a part of urogenital triangle. Yes, it is a part of urogenital triangle, because whenever we need a laxity, we need a room, we want to go inside the vagina. So these muscles will relax, they will go away. And this is also going to move outside, isn't it? So these muscles will somewhere going to help in urogenital triangle. But this muscle is also part of posterior, like anorectal triangle. So some books will tell you that it is a part of anorectal triangle. Some will tell you it is a part of urogenital triangle. So it is a central muscle. You can count in any one. And if you want to do the anorectal triangle, it's only one muscle is present into anorectal. That is an external urethral sphincter in a male. Okay. Or you can also count superficial transverse according to some different books. Okay. So, but yes, anorectal triangle, this one. But yeah, if you want to open, you want to defecate. So during defecation, this whole muscle, which is a circular, that muscle is going to relax from all the sides. So yeah, so they will be stretching over here also, no? Superficial transverse perineal, these fibers, they're also going to go for stretch. So there are some role of STP into the relaxation and even contraction also. So this is somewhere the central muscle. If I tell you that do Kegel and squeeze your pelvic floor. So once you will do squeezing, you are going to feel maximum squeeze around this part. Because of this central arrangement, all the muscles are going towards urogenital, anorectal, and sides. So this is a more central medial part. And this perineal body, once you will squeeze the pelvic floor, so these muscles will give you the sense of lifting upward. You will feel that you are trying to lift your pelvic floor upward. So the whole lifting is into the center. So these are the 4 muscles in a female body. There's a difference between female and male. The male, this is the image. And yes, urogenital, anorectal triangle muscles are same. Superficial muscle fibers, same. Ischiocavernosus muscle fibers, same. But the bulbocavernosus muscle fiber, it was splitted in a female body because female body has 2 openings. We have 2 organs into urogenital area. One is bladder and urethra, and we have a uterus and vagina. So these are 2 organs, but the male, they have only 1 organ, which is that penis. And penis is the one organ which is going to perform both the functioning, urination as well as sexual functioning, ejaculation. Both is going to happen from the one canal. So they don't need a separate opening. It's a one opening, but we need separate opening. We cannot urinate and the baby, the period cycle, this menstruation is going on. We cannot have this thing from the same canal. So we really definitely requires a separate opening because uterus is functional every month. It has to grow a baby has to come outside, and bladder has a different functioning. So because of 2 openings, our pelvic floor, our bulbocavernosus is split into 2 parts as per the encircling of the canals. It is going upwards. But in male, they have only 1 organ, so they don't need splitting of this bulbocavernosus. So their bulbocavernosus is, again, origination is from the perineal body. They will originate as a one muscle. The fibers will be kindly complete, they will be attached with each other. So they are not separate muscle. And they will go and insertion will be the base of the penis. It means if this is a penis, so the bulbocavernosus will be coming from this downward part, perineal body, and they will keep merging all the way and circling. They will grab. Look, my fingers, I'm grabbing it. So the bulbocavernosus are like this. They will grab it. So it's like a complete encircling. If you tie a rubber band at the downward base of the penis, so they are keep surrounding the base of the penis, and they're attached with the base of the penis. And if they're attached with the base of penis, so now try to differentiate the functioning in male. So they are at the bottom of the penis. So 2 things are going on sexually. Let's try to understand first the sexual. So what is going on? We need a filling of blood. So for filling of blood, 2 things are important for filling of blood. One is the pumping action from the ischiocavernosus. Pelvic floor muscles are going to work as a calf is pumping. Same way, ischiocavernosus will pump. It will drag more blood towards the penis, and they will start creating the erected penis, erection into the penis, because filling is going on. So yeah, ischiocavernosus will have the same effect, but bulbocavernosis, now the blood which is going towards the sexual organs, this blood should not fall back. So just to prevent the venous drainage, venous return, we have a work of nitric oxide is also going to create a constriction of the vessels. It will constrict the vessels. So the whatever blood is there, it will stay there, okay, from this base. So that is a one body physiology, but pelvic floor will also come into this picture. What they will do, they will work as a ring, okay. So once the whole erection is going on, at that time, after the till the time filling is going on, it will let the filling go. Once they found, yes, it is completely filled. So just to stop the venous drainage, it will create a very strong contraction at the base like this. So more stronger bulbocavernosis means more stronger contractions of the bulbocavernosis, means the erection which is maintained, which was there because of the filling, the erection will be maintained till the time male wants. Okay, so sustained erection. Sometimes, they lose erection very soon. Why? Two things can be responsible: nitrous oxide, because vasoconstriction is not there, or even the pelvic floor muscle is not strong. Bulbocavernosis is not contracting, so you don't have strength to create a contractions around the base of the penis. More strong bulbocavernosis means more better and sustained erection. Erectile dysfunction is a very big problem in male. And strengthening this muscle can help 70 to 80% if the problem is because of the pelvic floor. So male can sustain the erection. So it is a treatment of erectile dysfunction. Okay, so maintaining the strength of pelvic floor. That's why man's Kegel. We are talking about man's Kegel. They should do Kegel. So this is the role of bulbocavernosis in that sexual role. Now let's try to understand the role during the urination. So what happens during urination? This is the penis. They are urinating. Okay. So once the urination is going on, the urine should not, the residual volume of the urine should not stay here, isn't it? So after the end part of urination, once the urine came out from the urethra, okay, so it came out from this whole, what we are saying, bladder, very near to the urethra. So when it comes out, after this last stage, this bulbocavernosis will contract. It will give a strong squeeze. Because of the strong squeeze, the urine will go outside. So it is going to help in emptying of the bladder, or this urethra, not bladder, emptying of the urethra. So there's strong squeeze. And if the male, for example, if the flow of urine, we can also check the urine flow test for males. If the flow of urine is good, like I'll show you one diagram in assessment. So this is a part of assessment actually. So I'll make you understand about this. So we can also check that about how strong is the pelvic floor muscles. There are many different tests for assessment. So these are the two main functions of the bulbocavernosis in male. First, that maintain and sustain the erection. Second is the help in like emptying of the urethra. Okay, so this is the male and female superficial layer. This is very important picture which I kept. You can see that yes, this is ischiocavernosis, bulbocavernosis, superficial transverse perineal, perineal body, external anal sphincter, and can you see this white sheath? So all the muscles, the superficial layer, complete superficial layer will be covered by a very thin fascia. So any tightness, any damage to the fascia can create a tension into the whole muscle. Okay, so this is very important in case of spasmodic cases. So this is one slide. You can take a screenshot and read it. I already explained you about how ischiocavernosis is providing the erection and expelling the remaining amount of urine from urethra. Take a screenshot and read it, please. You can ask me if you want anything. And this is a perineal body into the center. He understood this. And now let's come and is there any question? Let me take a question first quickly. Dr. Sunita, it happened to me simultaneously defecate and urinate at the same time. Yes, dear, you have a weak pelvic floor. It's not happening all the time, only when we like I have urge to void. Yeah, it is not good. You need to check yourself and then do plan your rehabilitation. It is a stabilizer. Screenshot again, please could not take. Okay, dear. Yeah. Please take a screenshot of this slide. Moving on next, we understood the superficial. Okay. Pelvic floor, deeper layer, and superficial layer. This is the superficial layer. You can see this upper triangle, Bulbospongiosus, STP, IC, and downward external anal sphincter. This one. Okay, this is anus. All the anus is going to come here. So this deeper external is very thick muscle. It is kind of many. Okay, I'll send the PDF. Don't worry, I'll share the PDF. Okay, so this is the muscle. Thick band, very thick. So let's understand the downward part, external anal sphincter, this one. So can you see this is an anal canal which is coming outside, and this is all circular layer and circular around the anus. This is also very beautiful picture. You can see the width of external anus, quite wide. It has a longitudinal fibers, it has a circular fibers. It will completely encircle the whole canal. If your canal length is, as I told you, this much is only the anal canal. Okay, if this much is a length, so 80% up to here will be all this external sphincter. Okay, so all this you can try to tie a rubber band up to here. So this will be all encircled by external sphincters. So external sphincters are having the circular arrangement as well as longitudinal arrangement. Two type of fibers are present just to create the whole length of the canal. So this is, I already told you, this is the part of anal canal. And in this anal canal, these are the internal sphincters. This one, the internal sphincters. And these are the external sphincters. So this is all external sphincter. And we have again some kind of some fibers are coming up from the levator ani, deeper parts, upper 20% of the canals. Levator ani will also come into picture. You might have heard about one word, puborectalis. So that muscle is also going to come. So now, throughout this canal, maximum part will be taken care by the external anal sphincters. And if you want to understand the canal, yeah, this is what. Can you see? This is the external anal sphincter going on, and these are the longitudinal fibers of external anal sphincters. So very strong, thick muscle. Okay. This is again a picture you can see from out. This is outside out view. This kind of closing. Width, you can see the width also. Length also. From inside this picture, you can see the length, how lengthy the fibers are. So quite strong and big muscle this is. And what is the role of this muscle? What is role? What is function? Come on, tell me.
Control the stool.
So what? Supportive, stabilizer, what? Which term? Sphincters, sphincteric action. Okay. This is a muscle which is going to create a closing, opening, that kind of action. Closing and opening is the function of external anal sphincter. All right. Once we are talking about the superficial layer of the pelvic floor, you know, up to some time, it was believed that the whole pelvic floor, all these three layers, superficial, middle, and levator ani, the deeper layer, all the muscle, all the layers are supplied by pudendal nerve. But that is a wrong thing. Pudendal nerve is going to supply some parts of the pelvic floor. They are not supplying the levator ani, the deeper layer. They are going to supply the superficial layer as well as the middle layer. The supply of the levator ani is different, which I will tell you into upcoming slides. Okay. So the pudendal nerve is the one nerve which is going to supply this all superficial muscle, that fibers. So pudendal nerve is going to come from S2 to S4, and it will pass between the piriformis and coccygeus muscle. Yeah. I want to show you something. Yes, this one. Now here, it will come and it will pass from this particular, from here like this. It will going to pass from here. Between this piriformis and coccygeus. The muscle will pass, the nerve will pass from here. Two nerves on either side. After passing between piriformis and coccygeus muscle, it will leaves the pelvis through the lower part of greater sciatica foramen, and it will re-enter the pelvis through the lesser sciatic foramen. And after re-entering through this ischial tuberosity, around this ischial tuberosity, look beneath, this is ischial tuberosity. So beneath this, it will come and it will re-enter, and after re-entering, it is going to divide into three branches. Two branches will go upward, and one branch will go towards the inferior. So this is the inferior branch which will supply the external anal sphincter. So in case of your patients are having no control of the sphincters, okay, after any spinal cord damage, injuries around the spine, okay, in these cases where there's no control of urination and defecation, so we have to somewhere do the galvanic stimulation. We have to give galvanic stimulation to the patient. If they're not at all, any muscles are working, no functioning is there, no action is there. So we can start stimulating this area with the galvanic stimulations. And we can try to activate the nerve fibers. Okay. And this is a muscle which is going to go and supply the perineal body. So one in this, you can see going downwards fibers, and the muscles will go around this whole anus. It will go around urethra and vagina also, these muscle fibers. So there will be three branches: inferior rectal, middle perineal, and dorsal veins of the penis in male and clitoris in female. They are going to go towards that also. So this is a perineal. After supplying the perineum, they will go around the Bulbocavernosus. They will supply the Bulbocavernosus. And same third fiber will go upwards towards the clitoris. Again, I'm removing it. You just try to concentrate where they are supplying. Now tell me what will happen in case of mediolateral episiotomy. if the doctor has given mediolateral episiotomy to the patient, so they have cut these fibers like this. Okay, so there are chances they might damage some fibers of the nerve, pudendal nerve. This kind of things can happen. Not like this, it will be something like this, mediolateral, downward side. Okay, 5 o'clock, 5 to other side, 4 and 5 o'clock around the vagina, it will be like this. So there is possibility of damage this nerve during this mediolateral episiotomies. Okay, and if the female has gone through a 4-degree perineal tear, when there's a tear all around this part and even around tier 3 and 4-degree perineal tear, where there's a damage of external anal sphincter. I'll explain you what is the tears and what is episiotomy in upcoming slides. So these are some kind of damage which happened during the childbirth. Baby wants to come out and it needs some space. So sometimes doctors are creating space by giving the cut midline or mediolateral, or sometimes already female, if she will do hard pushing, there might be tearing of this all skin. So if the tearing will happen, you can understand that how many layers will cut into the tear. So it will be pelvic floor, complete pelvic floor damage around this perineal body. So Bulbospongiosus will be teared. That connection between the two superficial transverse will be also torn. They will be separated even during the incisions, midline and episiotomies. And not only the superficial, deeper muscles. This is a deeper layer. So this is also going to, on this you can see that we don't have superficial layer present here. It is a deeper layer. So they will be cut into a deeper layer also, those muscle fibers. So these muscles are going to, muscles and the nerves, that damage can happen. So nerves can damage during those things. Again, this is a picture which will give you that understanding that how pudendal nerve, pudendal means the nerve, pudendal means shameful actually in a Greek. It is a Greek word and meaning of the Greek word is shameful area. So this nerve which supplies the shameful area, they term this nerve as the pudendal nerve, shameful nerve. Okay, so this nerve is going to supply the whole this. So this is not a shameful area. Why it is shameful area? Like, it should not be, because I don't have sex always. And this area is related to the sex. Every day I don't have sex, but every day I'm urinating 6 to 7 times. Every day I'm not having sex. Every day I'm having defecation. So no, it is not, kind of shameful area. It is very important area for me. So now, why we are saying that this vestibular area is sensitive to touch, clitoris is sensitive to touch, or this mons pubis, because many nerve endings, actually, they are like, this is a merging where many nerve endings are coming in all together. So this particular site, look, this site around the mons pubis, labia majora, clitoris, this is the legs of clitoris here. Many nerves endings, millions of nerve endings are coming. And those nerves ending are not only from pudendal nerve. There are nerves, this is the main nerve, but there are nerves from the posterior cutaneous nerve, ilioinguinal nerve, obturator nerve, genitofemoral nerve. Many nerves are going to come into picture around this area. I will show one cluster of nerve endings, how they are going into this, the real picture. Not real, the demographic. I will show. So the superficial layer is supplied by the pudendal nerve. Even middle is also supplied by the pudendal nerve. Now, after removing the superficial layer, so we remove this. So we remove this. Okay. Now let's see the middle layer. So middle layer is this one. Can you see this one? Longitudinal fibers. Sorry, transverse fibers. Transverse fibers, all coming like these, no, these, they are coming like this. All the way from ischium as well as the pubis. Completely, they are going to merge around the urethra and the vaginal areas like this. And the fibers will also come towards the whole span, complete whole span. Big, deeper perineal layer is a deep, big muscles, big spans, which is coming like that. This is a middle layer. Okay. So let's understand the middle layer. Okay. So middle layer, we also call it as a deep perineal pouch. Okay. In this deep perineal pouch, the muscle will originate from this side, the bony prominences, all the way, keep originating, and they are going to go and merge around the canals. And more merging will be around the urethral canal, like this. So right side going like this, and circling, looping around all the muscle. Okay. This will go like this, this will go like this. So this is one side. Now other side will come. Again, merge. One muscles is going to merge with the opposite muscles. So this is how more merging of the muscle throughout the canal. And the merging of the fibers around the urethra, we call it as a urethral compressors. Okay, so this is a one part of levator ani, urethral compressors. Fibers are so many, they will compress the urethra. So compressors means close once required. So you want to hold the urine. So this is the muscle which is going to come. They will compress the urethra by creating a strong sphincteric action. So this is a muscle of urethral sphincter. Okay. Compressors. The same muscle is going to come and encircle around the vagina also. And they will form vaginal compressors, but not that much role into the vaginal compressors of this muscle, because you can see that there's a more distance between vagina and this ischium. So the effect will be not that strong. Effect is mostly towards more strong around the urethra, because effect is coming from all the way. 6, 7, 8, 9, 10, 11, 12, 1, 2, 3, 4, 5, all the way muscle is creating the compression around the urethra. Okay. So now you can see 12 o'clock compression, here compression, the whole muscles will put a compression over the complete urethra. So compressor urethrae is the main muscle of urethral sphincters, which help us in holding the urine. And yes, this is a vaginal compressors, and some fibers will keep going and they will merge into the perineal body. So this is the perineal body. So we call it as a deep transverse perineal muscle, which is merging into the perineal body. Again, stability. This is the muscle of stability, which provides the stability. And this is a muscles which provide the sphincteric effect also. If you want to see that in real time, this is the image. Urethral sphincter. So assume this is your urethra, length of your urethra around 3.5 to 4.5, and this is the internal, this is a canal, which is made up with the smooth muscle. So this is a smooth muscle, and all this smooth muscle canal, we call it as the internal sphincters. Okay, this is the internal sphincter. All this canal itself, it will create a compression and relaxation, squeezing and relaxing. So that is a smooth muscle action. So it is going to work as an internal sphincter. Now on the top of this internal sphincter, we have this external sphincter, which is, so this internal is not voluntarily controlled. So once it relaxes, urine will come outside. You can't control that. But yes, there are muscles which are wrapped around on this. You can control by creating a squeezing and compressive effect. You can squeeze this canal, and the urine will not come outside. You can hold your urine. So this is a very beautiful image where you can see this is a bladder upwards, and this is all urethra outer. You can see the outer orifice into the vestibular area. This is that particular part. So whole length is this much length. Okay. And again in this picture, bladder, urethra. And this is the clitoris, This outside, this one very, very near going downward is a Bulbocavernosus muscle on the top of the glans of clitoris. Okay. Very near to the bladder, we have some muscles from the levator ani. And now all this muscle, let me use a different color of pen. All this muscle, these, all are urethral sphincters, the compressors. So compressors will come like this. They will go and merge and circling like this. More merging is going on. Very thick band they are going to form around the urethra. And left side will merge with the right side. So strong merging is going on. Okay. So let me erase. I do too much of mess here. No? Not mesh, it's mess. Okay. So now you can understand this is the length. Assume the length is 100%. Okay. Out of this 100% length of urethra, long urethra, this image, you can see how the compressors will come and circle all the way throughout the length. So 20 to 85%. It is like altogether 85% part of the urethra will be covered by the urethral sphincter, this middle layer. Look, in this picture, you can see this all are urethral sphincter which is coming. They are merging. So it's altogether 85% part they are covering. Clear, everyone?
Yes, ma'am.
Now tell me, if the patient is suffering from now in this part, 85% will be the urethral compressors. More inner toward the levator ani, they will be 10% from the levator ani. That muscle is going to help. Compressors, but we called it as a pubo-urethralis compressors. We will understand that. And now 5% will be the role from the bulbocavernosus. Only 5% opening and closing action. Upper 10% is a supportive role coming from the pubo-urethralis. They will support it, creating the angle. And now these are the compressors. Once we are telling hold your urine, or you are able to hold your urine, it means you have a good, strong middle layer. The compressors are working good. What it specifies, the patient who is suffering from urine incontinence. So which muscle is the responsible?
Urethrovaginal sphincter is insufficient.
Compressors.
Yes,
compressors. Okay. So this urethral compressors, this middle layer is the layer which we have to work on. If you will keep giving this patient squeeze your pelvic floor, a complete pelvic floor, they will start squeezing. No, we have to give them the specific guideline. Squeeze your urine, hold your urine. Okay, create a compression around your urethra. So hold your urine. So once they will do this specific guidelines, they will train. We can train this specific. We can increase the specific movement around that particular area. Urogenital triangle. We can isolately train the muscle fibers. And that's why transvaginal stimulators, EMS, is one machines which are very, very effective in those kind of weak in urine incontinence. So those transvaginal stimulators, they will come from here inside the vagina, and they are going to strengthen these muscle fibers through vagina. Okay. So we'll discuss that in rehab protocol, but I'm just telling you that which muscle will be affected. So this is the main muscle which we have to focus whenever the patient is suffering from incontinence, not able to hold. So what is the muscle which is responsible for hold? That is the compressors. So middle layer, if you keep training the levator ani or bulbocavernosus, nothing is going to happen. You have to focus into the track, the passage. So some internal stimulations our patients requires in that cases. After crossing this, on that complete muscle, there will be one again fascia, it will be covered with the fascia, and now the deeper muscle will come. So we are going to take, can we take break for 10 minutes, everyone? And then we'll discuss the deeper layer.
Yes, ma'am.
Lovely. Or you can write down your questions if there is. All right. So how the session going on? Good? You have to say good. Thank you, Dr. Kajal. Hello everyone, I'm back again. Are you there?
Yes, ma'am.
Hi. So shall we start? There is 2 questions. Is there any other way to train these muscles other than asking the patient to hold the urine? Actually, we really need the patient cooperation in that, because these muscles, like whenever we are trying to create a strengthening, so they have to do active strengthening. They have to take an active role in this. But passively, yes, we can apply interferential therapy, we can apply EMS. Those are the different ways, but we will discuss about that in rehab assessment. You have to first understand the assessment and the rehab. What is the evidence that we can isolate each of this muscle? Yeah, there are supportive evidences. I will share the whole list of evidences with you. And does evidence support the longevity of benefit of EMS? Yes. Teba, please slow down a bit. All right, dear. Let me just slow down. Is it so fast, everyone? Very fast? Slow down. Okay, still, it might be the people who are like, it is every day for me. If today itself I treated 4 patients in Sunday. So, it's very, very easy for me to understand pelvic floor. I'm doing it since many years. So my pace it can be high for those people who just coming and in the contact of this muscles, understanding, knowledge, this material first time. So it can be kind of fast for them, but I understand. I respect. Okay, so let's start again. The deeper layer of pelvic floor. Deep layer, what we also called it as a levator ani muscle. And this layer is the one layer which is giving a bowel shape, hammock shape. Okay, that kind of shape is given by this muscle. There is difference between looking at this muscle. This is not giving bowel shape. This is not a bowel shape. Okay, not even the superficial layer and not even the deep layer. It is not a bowel shape muscle. But yes, this is bowel shape muscle. Bowel. Okay, it can hold. So once we are talking about the bowel shape muscle, so we are talking about this muscle, levator ani muscle. And this muscle, because it is going all the way from the pubic symphysis, whole big muscle. This is deep layer and is going from all the way from pubic symphysis. It starts and its fibers comes here. Look here. These are the fibers back. All these fibers going towards the coccyx back. So starting from pubic symphysis, it can go all the way at the back. And by giving the openings into the center, this is one opening for urogenital part. This one is the urogenital part from where all urinal and genital, like urethra, as well as the anal canal is going, vaginal canal is going to come. And this posterior part, this one is the anal opening. Okay. This is not, this is just a screw. This is just a screw. So this is openings. So this particular anterior part, this one, we also name it as a hiatus. Okay, urogenital hiatus. This one is up. This one. Where is this one? This is a hiatus. Okay, this one all the way like this, and urethra and vagina. Or let me just turn like this. Assume a clock, big clock. Okay, the clock, 12 o'clock will be the pubic symphysis, 6 o'clock will be the coccyx back here, and both sides 3 and 9 will be ischial tuberosities like this. So assume a big clock on that. Assume a small clock on this. So once we'll assume small clock on this, so again, this 12 o'clock will be towards the pubic symphysis like that, and 6 o'clock towards the tailbone. if this is the vagina, this hiatus, 12 o'clock will be towards the pubic symphysis always, and 6 o'clock will be towards the downward side, posterior side, like this. So this is a levator ani muscle, and very big, coming from all the way from sides, going in here. This is obturator internus. From anterior, it is coming obturator internus. And this is, you can see obturator internus here. Okay, this one, this one. And from this obturator internus, the muscle is originating the levator ani. The origin of this levator ani, one part is from the obturator internus. Can you see the fascia of obturator internus? This is all you can see the span of the muscle. All right, let's understand that. And about this important muscle, it comes in connection, direct connection with the organ. Like this, look. So if something happened to the organ, let me just bring, okay, something happened to the organ that can give referred pain to the fascia or the structure, to the pelvic floor. So organs can directly affect the pelvic floor, and pelvic floor, if pelvic floor is tight, for example, or if pelvic floor is loose, it can directly affect the organ functioning or the positioning of the organs. So they have a core, they have a very good relation with each other. So endometriosis happens to uterus that can give adhesions to pelvic floor. Interstitial cystitis, which can create inflammation in the inner part of this, can create too much of no problem with this. It can do inflammation of all this urethra. So you can understand that we have urethra, which is going to touch the pelvic floor, going to cross from the pelvic floor, compressors. So they can also get inflamed. So anything with the organ can affect the muscle. Anything happen to the muscle can affect the organs. Okay. And this is the muscle which is supporting it. So this is a supporting muscle. All the organs are resting on this muscle actually. Other muscles they're piercing, so they're sphincters. But this muscle is supportive muscle when we are talking about the pelvic organ prolapse. So that happens because of the weakness of levator ani. Okay, this muscle is not strong enough. I'm going a bit slow. Levator ani, or the deeper layer, especially the deeper layer, is made up of two parts. One is levator ani muscle and one is coccygeus muscle. So these two parts are forming the deeper layer of pelvic floor. So this green part is levator ani, and this is a coccyx. So these two are forming the pelvic floor. And this is a piriformis accessory. This is the obturator internus accessory. The levator ani is the most important muscle of pelvic floor, which gives bowel or hammock-like shape to the pelvic floor. And this is a muscle on which organs are resting. Its main function is to provide support to the pelvic organ. This part of the muscle, deeper muscle, is having the highest resting tone. 70% of muscle fibers are made up with the slow twitch muscle fiber, and 30% muscle fibers are made up with the fast twitch muscle fibers. Once we're talking about the compressors, or the superficials, especially superficial layer, external layer, Bulbospongiosus, Ischiocavernosus. So they are the fast twitch muscle kind of fibers. But these levator ani fibers are mostly 70% fast twitch, slow twitch muscle fibers. Slow twitch muscle fibers is there to maintain muscle tone for long period, to sustain contractions and provide postural stability. 30% type of even this slow twitch muscle fibers, like, they have always, this levator ani always holds some kind of this tension. Actually, it's not always completely relaxed. No, it has some kind of always action going on, this kind of sustaining some kind of contraction. If I'll say not 100%, but 20 to 30%, it's always in a contracted side. Okay. This is why, and more, this is why, whenever we are sleeping, that like for 8 hours, 10 hours during the night, we don't, like there's no incontinence during this time, during when we are sleeping. So this muscle maintains the tone, the slow twitch muscle fibers, they maintain the tone of this muscle during the sleep, and it prevents the incontinence. So it is very important muscle for us. If the weakness happens into this muscle, so people can even start having the nocturnal enuresis, nighttime voiding. Even you might have observed in kids or the many people when they void on the bed. So in those cases, that the supportive, the tone is somewhere altered of the levator ani. The deeper layer is the culprit on that cases. 30%, so it maintains the tone all the time. Right now, you are sitting with me, the muscle has a tone. 30% type 2 fast twitch muscle fibers to increase muscle tone quickly. So suddenly, if there's a sneeze comes, so once sneezing, coughing, you want to lift something, lifting up, you are jumping, dancing. So whenever the sudden increase intra-abdominal pressure is going on, any activity which increase the IAP. So once this is going on, so this muscle are because of the fast twitch action, they will give a counter pressure to the IAP. So they will work as a trampoline. So once you will put the pressure from the above, so the muscle will work like this, fast twitch action. They will generate a strongly pull of they have angles and the supports. So they will pull the muscles towards the pubic symphysis. So always levator ani pull is from back towards the center. So like I am holding you, I'm holding you like this. Okay. One side pelvic floor, levator ani, other side pelvic floor. They are merging around the canals. Okay. So sudden, so I'll do sudden action, I'll do that. So suddenly the whole pelvic floor will move upwards, inward, upward movement. So that movement is coming from the levator ani because of this fast twitch muscle action. And this can happen anytime. I'm going to sneeze anytime. So once I'm going to sneeze, so before that, if your pelvic floor is strong, they will pull it towards the pubic symphysis because of this immediate action. If your pelvic floor is strong, so you will not leak during sneezing and coughing. So trampoline action is because of the levator ani. Reflex contraction of both types and they generate a strong reflex as a slow twitch and fast twitch. The complete tone, by maintaining the tone and action, they create a strong reflexive contract. Sometimes you can't control it. It is controlled by the CNS. The brain knows that how to come into picture. The reflex is generated by that. So even once we are talking about sexual activity, once the female is aroused, okay, the penetration is going on or the masturbation is going on around the clitoris. So there's a time when she's going to hit the orgasm. So during the hitting of orgasm, this particular time when the maximum tension is going on in the whole body and maximum stimulation is going on in the mind, so that sensation at that time, brain will create this sudden reflex. And because of this sudden contraction of this pelvic floor as a whole, levator ani as a whole, this contractions, levator ani, this reflex will be very strong, and this reflex is responsible for orgasm. If the female who feel that, I don't know what is orgasm. I was feeling orgasm before, but no, I don't feel like orgasm anymore. So in this case, we can understand this reflex is somewhere weak in her case. So pelvic floor is weak. So reflexive action of pelvic floor muscles are going to help during orgasmic stage in both male and female. So if you have a strong pelvic floor, you will have a better orgasm. Reflex contraction of both type of muscle fibers are important for even pelvic organ support. and keeping urinary fecal continence and onset of sudden activities. Levator ani, this muscle, is further divided into different parts. Not levator ani. I'm sorry, this word is wrong. Not levator ani. It should be the deep layer of pelvic floor. So deep layer of pelvic floor is further divided into three parts. So first part is the origin of the fiber is coming from the pubococcygeal pubic bone, inner part of the pubic bone. They will originate and they will go back. And insertion will be around the coccygeal body, not into the tailbone, but not into the coccyx, but the coccygeal body. The insertion will be. So now the fibers, let me take a different color of pen. Okay, so the fibers will come here, they will keep originating and they will keep going at the back and they will insert here in coccygeal body. So this name of this muscle is the pubococcygeal muscle, pubic to coccyx. Not directly they are attached with the coccyx, but still the name of this muscle is pubococcyx muscle. Right side and this is the left side. One muscle. Second muscle is going to come from, they are going to originate from the fascia of obturator internus. So this is the obturator internus. From this fascia, the muscle will originate and going to insert into the coccygeal coccyx. This muscle is going to insert into coccyx like this. Some part will be around the coccyx. So this is the second muscle, second part of the levator ani. Ilio from ilium, like it's like from ilium, or but not from the ilium directly. Actually, directly is from the obturator internus fascia, and insertion is going to happen around the coccyx. This is the second part. And the third part, and these two, pubococcygeus and iliococcygeus, these two muscles are levator ani. These two muscles, we are calling it as a levator ani. Now the third muscle of the deeper layer is the ischiocavernosus. So that muscle is going to originate from the ischial spine. So this is the ischial spine, and that origin is from there. And this is going to insert into the sacrum part. So sacrum, around the sacrum, the insertion is of this muscle. And around even the some part around the coccyx, but mostly into the sacrum. So these are the three layers of deeper, three parts of deep layer of pelvic floor. Pubococcygeus, iliococcygeus, and ischiocavernosus. Three parts. Now let's understand the first part. Pubococcygeus, more central. So pubococcygeus is going from anterior to posterior. So anterior to posterior. So what is the function of this muscle? Coming from anterior to posterior. Is it working as a stabilizer? Yes. Some role in stability. Answer me, girls. Are you with me? Yes or no? Yes. Yes.
Yes.
Yes. They are going to help in maintaining the stability from anterior to posterior. And if I'll say, so this is the most medial muscle, medial towards the center. So central muscle, pubococcygeus. And most posterior muscle is the coccygeus. It is more posterior at the posterior part. And this is a middle. The iliococcygeus is the middle part. So now the pubococcygeus, which is going to even the this one is also coccygeus muscle is also a muscle of stability. Okay, this is also a muscle of stability. This is also a muscle of stability. So levator ani provides stability. And now organs are resting on the muscle. So somewhere once the uterus is there, or rectum is there, or bladder is there, they are going to, their surface is going to come in contact with the surface of pelvic floor. So they are supportive also. They are supportive and they are stabilizer. Now, they are also going to go through that, this specifically the pubococcygeal muscle. Now, canals are also passing through this. So once the canals are passing, these muscles are somewhere looping around the canals. So once looping around, so sphincteric action is also there. Okay, not creating a compression, but holding the angle, so maintaining the angle. So all this pubococcygeal is going to maintain some kind of angle inside. So let's understand our first muscle, pubococcygeal muscle. Okay, we'll understand this levator ani nerve supply later on. Yes, piriformis and obturator internus is an accessory muscle. Now let's understand the first one. Pubococcygeus. Pubococcygeus. So this muscle is going to, we can subdivide this muscle into two parts as per the anorectal and urogenital triangle. Now, that urogenital triangle which we were discussed and like superior, like in that superficial layer. So same way, this part is also having, you can also divide this area into two triangles. So that was a superficial. You join that upper triangle and the lower triangle. Okay, you just join your fingers together. Upper triangle and lower triangle. Same way, we have to understand, you have to understand downwards. So triangle above than this line, this one, like urogenital hiatus and the anorectal hiatus, that one. So we have to understand these two triangles in the levator ani also. Now, share the screen. Now let's come and try to understand the pubococcygeus muscle. Pubococcygeus is, we also call it as a pubovisceralis. It is further subdivided into two parts, pubovisceralis or puborectalis. Okay, so pubovisceralis is anterior hiatus. So now from this pubic symphysis inner part, the muscle will originate like this, and now it's going to come and meet the first organ which is passing from here. Now, which organ is passing from here? The organ is urethra. So this is an organ which is passing from here, urethra. Can you see this is a urethral opening? So urethra is passing. So what happened? This muscle will come from there, from pubic symphysis. It will come, it will keep going, but it will create a encircling around the urethra. It will merge with the opposite fibers of the pubococcygeal muscle. So this side fibers merge with this side of fibers. It's like this kind of merging. Can you see this kind of merging, fibers merging? So they will start looping around the urethra, and we call this muscle as the name of this muscle will become pubourethralis. Now, again, come into this picture. I told you that there is some fibers from the levator ani is also going to come and support. So this pubourethralis will come and they will loop around this one, around there. Loop around. Loop around means they will hold it. So means my pubourethralis, my pubo fibers are coming, and I'll come from this side also, right? And I will merge like this and hold the organ, hold the canal towards pubic symphysis. So once you want to hold, so fast twitch action, so this hold will happen at that time. If they will compress the urethra from the top, so urine will not come into the canal, and we can prevent the leakage. So this kind of up, like holding the particular, bringing the urethra towards that. So pubo-urethral fibers are like this. So right side, left side, and merge with each other. They do like this. Pubo-urethral fibers. Next, will be, they will go, more fibers will come from pubic. They will keep generating, keep originating actually, not generating, keep originating. And they will go and encircle the next canal. Next canal is a vagina. So this is a vagina. And can you see this, this one, this part is going on. So they will encircle the vagina, these fibers, and they will become, they will again left with the right, they will again merge with each other around the vagina, and they will become pubo-vaginalis. So pubo-vaginalis, again a loop which will hold the vagina. So during, like I will hold this like this, okay, bring it towards me. So during the insertion, like for example, during sexual activity, when penis is inside, so at that time, it will hold the penis towards the pubic symphysis, towards the clitoris. So that action of pubococcygeus muscle, pubovaginalis muscle, is going to bring the particular organ which is inside towards the center, and that organ, the penis, is going to compress the legs of the clitoris. Please mute yourself. So that is going to pull the pressure of the penis towards anteriorly. It will pull, closing effect, pull. So once it will pull, so means the pull will be, it will fall over the, it will compress the legs of clitoris and vestibule of that clitoris. That is going to give more sensation during sexual activities. So pubovaginalis is a muscle which is going to help during this sexual functioning. And another thing is, pubovaginalis is a muscle if you are inserting a finger inside the vagina. Okay, so doing the transvaginal examination, assessment, or rehab. So once you are inserting your finger, we ask our female, squeeze. So the squeeze, what is going on actually is the squeeze from, more squeeze you will found, it is coming from the 4, 5, 6, 7, 8, that downward pull, more squeeze. That loop is pulling your finger. So the finger, when your finger is more inside, once your finger is entry, Bulbospongiosus. Once your finger is inside the tunnel, so two parts of the tunnel, outside and inside. So outside, Bulbospongiosus, inside is a pubovaginalis. So you are in, you can touch the pube. So that squeeze is the squeeze of pubovaginalis muscle. That will squeeze your finger, and we will feel, yeah, there is a squeeze. Okay. And you will feel that your finger will be pulled upward, inward, and the pull will be towards the pubic symphysis more. So this is the second part, pubovaginalis muscle. Third part, this muscle, same muscle will keep going, origin will keep going on, and this is going to now go and merge into perineal body. So this is the perineal body, which is present, hard kind of structure. They will merge into the perineal body. And what they will become? Puboperinealis. So if they are merging into the perineal body, so means this muscle is a muscle which is going to provide stability from pubic symphysis to the perinealis, that particular hard tissue. So puboperinealis. Now same, the muscle will keep going back, and they are going to now merge into the anus. Sorry, merge with this around the anus with the external sphincter. I told you around that what we are saying, the anal canal, that whole external sphincters are merging like this. Now this part of pubo, this part from this pubococcygeus will also going to merge into this, and it will give more strength to those fibers. Okay, so this is the puboanalis muscle fibers. which is going to support, increase that compressions and effect of this sphincteric effect actually by giving more muscle fibers towards that. So this is the fourth part, puboanalis muscle fibers. And after going to this muscle will go again. There will be another organ which is a rectum. So this is not going and around the anal canal. This is going and create a loop around the rectum. And we call this muscle as a puborectalis muscle. So it will keep coming from here and wrap around the rectum like this. From not like this, and like this merge, like this merge. They will merge with each other with the opposite muscle. So more looping of this. And once again, we can understand about the function of this puborectalis. It will keep holding the rectum anteriorly. So rectum is not like this. Rectum is not like this. The rectum and anal canal, like they are in a same plane, a 180 degree. They don't lie in the same plane. This angle, this rectum will be pulled anteriorly and they will be like this. Like this. Rectum will stay there. And this angle, this pull is because of the puborectalis muscle. They will maintain the angle of 90 to 100. Right now, all of us, we are sitting, listening to this webinar. Our puborectalis angle is 90 to 100. So it is a kink. It will keep pulling this kink. And now, because it is a holding effect. In this way, the pressure will always stay into the rectum. If the stool, feces, everything, they will not come around the internal, it will not stimulate the internal sphincters. It will not fall over the internal sphincters because of the pull. It is something that I am pulling my finger like this, pulling it like this. Okay. So rectum, I'll pull it like this. So this angle will be maintained. Okay. It should not be straight. It should be always this. And this, but if your puborectalis muscle is strong, then only the pull will be strong, hold will be strong, and your leakage of stool will not be there. Okay. And if this pull is not strong, levator ani is not strong, the angle will be not strong because muscle don't have strength, it don't have a power, or it has a power, but it don't have a endurance to hold it for long time period. So that can give you leakage of, so means like pull this leakage of the stool from the rectum towards the anus. After that, the next muscle will come into picture. How strong is your external sphincter? If your external sphincter will strong, it will not let it leak because already puborectalis levator ani is weak. But if you're this strong, that is a very strong muscle outside. If that is also weak, so you will leak your stool. And if the watery stool is also like liquid, watery, that kind of stool, you might leak it. Okay. And if stool is not, it's a hard stool, you might have that sensation that you have to go and just void, and you will go and you will void, because that is what is important, is this angle, maintaining the angle. It is a puborectalis. We will read this slide. Just let me just finish here. So now here another organ is there, rectum, and that will be pulled by the, rectum, like here. So that will be pulled forward by the puborectalis muscle. So these are 5 subdivisions and 5 different parts of pubococcygeal muscle. So now, if and this can work isolately, like like one time one things can work. So you want to hold urine. So more 80% focus will be into holding the urethra towards that, because your focus is around because brain. That's why educate your patient completely. Like he can cooperate with you, he can understand. So education, knowledge about this system is very important. We cannot create a strength until your patient is not well educated about the pelvic floor. So we can make their focus around the particular area. We can tell them to, focus into this particular part. So in this image, from pubic to urethra, pubourethralis. From pubic to, muscle fibers are going all the way here, pubovaginalis. Pubic to might be perinealis here, and then analis. pubic to rectalis. And can you see all these muscle fiber, pubic to rectalis? These all are pubic fibers coming. And they are not going all the way up to the back. They will always stay around this particular pubic, like, anococcygeal ligament, not ligament, the body. So this is a pubic fiber, the first median fibers, and the role of the fibers are maintaining the angles around the orifice, all the orifice, and supportive, like stability also. So stability, sphincteric action, or sphincteric means pulling the angles in and out. You want to hold, they will pull it towards pubic symphysis. You want to release, the pull will be towards the tailbone. This is the deeper layer. And again, a beautiful demonstration from our like pubic symphysis. First, this one. Second, around the vagina. Third, to pubourethralis, pubovaginalis. Third, around the perineal body. Fourth, around the anus. External sphincter, puboanalis. And fifth, all the way encircling the rectum. And keep pulling the organs towards the action will be like this: contraction towards pubic symphysis, relaxation towards the tailbone. This kind of action will be there. So this is the pubococcygeus. Now let's talk about the ilio. Now ilio will come from here. We were having this obturator internus, that particular arch, the muscles will originate and it will keep going backward, and insertion will be again into the anococcygeal body more, but they will also insert into the tailbone. This kind of insertion. One fiber will merge with the other fiber. So this is iliococcygeal, supportive, more supportive, and even provide the stability as well. And this is the last from ischial spine. They will come and merge with the tailbone as well as the whole sacrum. Not whole sacrum, maximum part of the sacrum. They will merge into this. So this is the last ischiocavernosus or coccygeus muscle. These are the three parts of pelvic floor. Now I want to ask you one question. Try to understand what will happen during the childbirth. Baby is going to come from this vagina. Okay. Don't have image, otherwise I could have shown you. What will happen during the childbirth? I'm sending you a picture on the group. What will happen during the childbirth? Try to think, everyone. With this muscle, what will happen with this muscle? I'm sending, yes, got it. I'm sent. Pubococcygeus muscle specifically around like those these muscle fibers. Try to understand these muscle fibers. Baby is going to come. I have shared a video with you, not video, image. Childbirth, big baby is coming. So for example, first stage of the labor is over. Baby now, cervix is dilated. Baby came here into the passage, vaginal canal. Vaginal canal is already it is open. It is stretchable canal. It can expand, and baby is into this. after baby coming into this particular, by crossing the canals, baby head will come here and it will stuck here around the pelvic floor. If the pelvic floor are tight, spasmodic, some kind of adhesions are there, it will make the childbirth difficult. It will stuck here. And if it will stuck here, they will tell the female to push. But still, pelvic floor muscles, they will not release this relaxation. This is tension, some kind of scarring, adhesion, anything can happen. That can keep creating the tightness, and might be the fibers which were merged with each other, they were a very strong merging, adhesive fibers like this. So they will not let the vagina open up, because internal, the floor will not open, okay? And if they will not open, the baby will stuck there. These are some cases where they have to go for, they were doing vaginal delivery, but they have to go for emergency C-section, baby stuck there. So pelvic floor tightness can be one possible cause at that time. Okay. Or if baby is coming outside. So once baby is coming outside, again, looking at the picture which I sent you, try to understand that much of big baby which is going to come. The picture which you are looking at outside is the Bulbocavernosus, opening of the Bulbocavernosus. So how much stretching is going to happen into the Bulbocavernosus? So Bulbocavernosus is a muscle which is a separate muscle, which is coming from, Bulbocavernosus is a separate layer. Okay, one layer is coming from here, one layer is coming from here, and they are merging into the center. So this muscle can relax, open up, widen up. But if the muscle which is here, pubovaginalis all around this area, or back posterior muscle to the pubovaginalis, puboperinealis, puboanalis, all these muscles were from right side merging, left side merging. They were merging like this. So these are going to create separation. Complete. Didn't receive image, Shirley?
Yes, ma'am, me too.
But you are on the group?
Yes, ma'am.
Just 1 minute. Hi, Pallavi, I'm sending you link. Give me some time, huh? Yeah, bye. I don't know. I have sent on the pelvic floor 23. I don't know why you didn't get it. You are not on any group. Just send me hi. So you understood what will happen. This muscle fiber, right side pubococcygeal, this muscle, they are merging and creating this pull. Now there will be separation. 85% of the whole muscle, pubococcygeal, going from front to back. So there will be less separation towards the urethra. But because after urethra, we have this. So urethra is also already, it is secure, it is anteriorly. So the pubourethra will not separate. But all the muscle fiber after the urethra, like pubovaginalis, analis, they are going to get for this kind of stretching. Not only stretching, they will separate from each other. Studies are saying 85% of the muscle, they separate from each other. So this, and then baby will come outside. And this is the reason of what? Pelvic floor muscle weakness after that. Because after that, postnatal time period, relaxing hormone will come into picture. It will create a strengthening, not strengthening, it will create a healing. So those muscle fiber, they will come again, they will heal with each other. But healing is a natural process, strengthening is not a natural process. So those muscles will always, they will left for life weak muscle. They will not have that strong strength and that pulling, holding effect. That can be wrong. And now, how many times the female she conceived? Again, it is depending upon how strong, how good rest she has taken. There was no overloading over the pelvic floor after that. She didn't involved in some kind of high intensity jumping exercise very soon in her life. So no loading goes there. She has taken enough rest. Relaxing hormone has done its work. There was a good nutrition also. So yeah, but still healing is good. But strengthening is it will be always kind of weak muscle, and that is the problem. The muscle will start losing the support from the organs and ended up into prolapse. It can end up into prolapse later on in life because the strength is not there, weakness is there. And I have seen many cases, and out of whatever cases I have seen, 90% of cases of prolapse are the cases from vaginal delivery, normal delivery, because rehab is missed. No one is doing rehab. How many of you are mother and you got that rehab in your life? I don't think so. Any one of you had got the rehab. And we are the people who has to now come into the picture. And after postnatal pelvic floor rehabilitation is very, very important part. If you really want to give a quality of life to your female, if her pelvic floor is weak now, the leakage will come. The leakage of urine, leakage of stool, leakage of organs. Organs can start falling downwards. Or that very important part of my life, sexual activity. If the pelvic floors are weak, if pelvic floor is weak, I might don't feel that grabbing. We can understand that in this vagina was a smooth muscle. It stretch out. So once again, sometimes the ring-like structure inside the vagina, they got flattened. So flattening of rage also happens. So vagina can always be the loose and lax vagina inside. So vagina will not give that kind of stretching or compressive effect. Okay, because it is a flattened vagina. So I will not have proprioception if I touch it, because the rages are flattened. If rages are circular, they will add up into the proprioception. But they are flat surface, so they are ridges like this. So they will give me proprioception. The flat will not give me that much proprioception. So it is going to affect my stimulations, sexual sensations. But if still the vagina is lax, but my pelvic floor is strong, I can feel the grabbing. I can have a strong reflexes from inside. I can feel orgasm also. Doesn't matter if my vagina is loose or lengthy, whatever, it's a laxity inside the vagina. Nowadays, there are many doctors will tell you do laser inside vagina, vaginal tightening, vaginal rejuvenation. What they will do, they will try to do with the smooth muscle. But can you train the smooth muscle? No, you can't train the smooth muscle. You can't do anything with the smooth muscle. But they will try to create an inflammation inside, so they can have a proprioception. So laser techniques, all these techniques are failed actually. They are not that much, they are not going to give you the long-term solution. What is the long-term solution? If you strengthen the pelvic floor, holding will be there. You will feel the penis because you're holding, and sensation are also at the lower part. So will definitely, this compression will put a penis compression over the clitoris, and you will hit orgasm. So strengthening of pelvic floor is going to improve the quality of life in all the aspects. It can be the support, hold, or it can be the, what we'll say, sexual, which is very important. Okay. So this is the pelvic floor. So shall we take question after this? Yeah, let's read this session first. The puborectalis muscle is a muscular sling that wraps around the lower rectum as it passes through the pelvic floor. At rest, the puborectalis is contracted and pulls the rectum forward. As I told you, that pelvic floor muscle, levator, and I always have some kind of action, this kind of tension, not tension on a wrong way, but that contraction, that functioning. And it will create an anorectal angle. This angle and the puborectalis muscle assist in preventing defecation into the rectum. That helps to prevent passive leakage of the stool. And the angle which it is maintaining is a 90 to 100. And if you want to, now there is we will discuss about this position, squatting position and sitting position. So, but try to just understand, this is not a relevant picture for today's topic. This is the picture when we have to give them that right positioning of passing the stool, how to relax the pelvic floor muscle. So now how to relax, in which case the pelvic floor will be more relaxed. Is it in sitting position, sitting on the commode, or sitting on the squatting position? So we will discuss about this in upcoming rehab session, but this is not that much relevant here. So yes, we discussed about the iliococcygeus, how this muscle is coming from this obturator internus, going there and merging is into the anococcygeal body as well as the tailbone. So the coccyx actually. So this is the iliococcygeus. It is a stabilizer or it is a supporter. So this is again a beautiful picture, how you can see iliococcygeus is going on. So iliococcygeus, 80% part is coming from the obturator internus, 10% is coming from pubic symphysis, and 5% is coming from the spine also, ischial spine also. And next is the coccyx, situated most posterior. The apex is inserted on the tip and pelvic surface of the ischial spine, and the base is attached to the fifth sacral segment and lateral margin of the coccyx here. So it is attached with the both tailbone as well as the sacrum. This is the coccyx. And this is a beautiful levator ani. You can see pubo-urethralis, pubo-vaginalis, pubo-perinealis, pubo-analis, rectalis, and this is external anal sphincter. And this is a test for all of you. Tell me, this is the last slide. Tell me what is A, B, C, D, and E. We are stopping here. If you have any question, please write it down. This is again some supportive structures. Ligaments, I was telling you, which is all holding. So we will discuss about this also. So this is a ligament coming from the pubic, holding the urethra, ligaments coming and holding the cervix, coming from the sacrum, holding this anterior cervical ring. So many ligaments are all, so there are many supportive structures. So they will maintain the position, strong strength into the ligament, they will maintain the position, they will not let the organ fall over the pelvic floor. So pelvic floor will not be loaded if the ligaments are strong, good enough. And if the ligaments are tight, they will pull the pelvic floor upwards. They might give a tightness into the pelvic floor. If the ligaments are tight, they can pull the sacrum anteriorly. They can pull the pubic symphysis anteriorly. So they can give a lot of pubic symphysis pain, back pain, pelvic floor pain, or if they are tight, all the structures are tight, they will pull the organs towards the abdominal cavity. So tension, the organs will be under the tension because of the restriction, which is all the way from all the sides. So tight pelvic floor can pull the organs upward, more inward upwards. Organs will not be free to perform the action, and they might show you the pelvic pain. Yeah, so I am stopping here. The function are, I want you to just take a screenshot. We already discussed this function: pelvic support, stability, sphincteric function, and the sexual function. Okay, everyone. So we are going to stop here. Now we have to understand the more patient education, practical sessions, which is going to assessment, rehab, everything. Thank you so much. Let me go through that. What questions? Is there any question? Kajal, you might now got how many muscles altogether? The levator ani is again subdivided into the different parts. So calculate all, you will get your answer. It's altogether 15 muscles.
Yes, ma'am, I got the answer.
Got
Thank
it?
you.
Lovely.
Yeah.
Thank you. Thank you, everyone. Any question? Let me stop. Thanks, Doctor, for slow down. Thank you. Thank you. Yeah, you can leave the session. The people who are there from Dubai, please stay. We have an important announcement to make. All the people can leave from Malaysia, India, Bangladesh, you can leave. Thank you. Thank you, thank you, thank you so much. Hi, Dr. Divya or someone from the mentor team?
Yes. I'm here, Basma. I'm here.
Okay. Let me, which view? I have to unpin myself or somewhere, remove pin. Okay. Yeah, hi. So we covered that anatomy and physiology of the
Yes.
pelvic and even the functions also. I'm so excited to come to Dubai And without wasting any more time into anatomy and this theoretical part, we will directly try to understand the organs, their functioning, and how they are creating problems, what is incontinence, what are hypotonus problems, and what are hyper. Muscles can become tight. Once they are very tight, they can give painful sensations in urination, sexual activity, defecation, pelvic pain, chronic pain, back pain, vulvar pain, vestibulitis, all these things can come. Pudendal neuralgia, all these things can come. So if the tight muscle is tight, how to assess that and how to relax that, we are going to understand in the sessions. Same way, the conditions which is because of the weakness of the muscle, we will also understand that. Urine incontinence, fecal incontinence, laxity issues, prolapse issues. Yeah, the organs are falling backward. This is what someone of you have asked. So all this we will try to understand into the sessions. Workshop.
Okay, thank you so much, Dr. Sunita. Looking forward to the practical workshop. To all the registrants, please, if you have anything to ask, kindly unmute yourself and you can ask Dr. Sunita right now. And regarding the recording of yesterday's session, please suggest us what time is suitable for all of you so that we run the session today evening or tomorrow. Any time is feasible for us, but you need to give us the feedback that what time is good for you. The recording cannot be provided because we also tried our best to provide it through the email or through the WhatsApp or any other platform, but it is not possible.
And sharing is not also good from my side, because sharing recording, it
we can
go
understand
viral. Yeah, it can go viral. So that's why it's another cause. We can run it for you.
Yes. So either you can put it in the chat box, what time is suitable, 3 hours, we can say 6 o'clock till 9 o'clock today. So all of you, I think we have the participants from Burjeel Hospital and one participant from Saudi, Dr. Bayan. She could not attended yesterday, Dr. Mariam. So please come forward and tell us what time can be beneficial. Rasam Hameen, 7 p.m. today.
So what will be the India? I have to run on my Zoom.
Tomorrow, the yesterday session is with me, I think. So
Okay, yeah,
I can run it.
Okay, lovely.
Yeah.
Okay.
Dr. Bayan says 7:30 p.m. today. Okay, 7 and 7:30. Dr. Mariam, if you can tell us your time, please. Dr. Sumi and Dr. Anishka. Dr. Anishka was a lot concerned about it. Anishka, you can also tell us, please, what time is feasible for you today. Okay. Evening is okay. Okay, I think if we do it from 8 onwards, it will get late. It is fine if we start 7 to 10 p.m. Today is Sunday. I think you have to sacrifice your evening today. No entertainment for Sunday today.
That's right.
Mariam. Okay, Dr. Mariam, 7 p.m. So 7 p.m. for today is finalized. We will run it today, 7 p.m. till 10 p.m. Okay, all of you, thank you so much. So Dr. Sunita, if you are busy at 7 p.m., it's okay. I will run it here.
Please, yes.
And we will see if anybody wants to have the recording from today, which is with you. So we will see it yesterday. Although I did not get any requests for today's recording. Okay, it's only regarding yesterday. Yes.
It was here today.
Yes. Thank you so much, Dr.
Thank you
Sunita,
so much, everyone, for your nice comments.
Yeah, and I think PDF has been shared already, or it needs to be shared.
We share. No, we didn't. I don't know. I'll share.
PDF.
I'll share.
Okay. Okay. All right. Thank you so much, everybody. Looking forward to meet you all.
See you.
Thank you.
Bye.
Thank you. Bye-bye. Thank you, Dr. Sunita.
Thank you,
Bye.
dear.
Thank you, doctor.
Bye. Bye, everyone. Bye-bye.
Bye-bye.
I'm ending the session. Bye. Bye. Bye.